The only difference is the terminology is different, right? The energy, the approach, the heart behind it is exactly the same. The personhood, the value of seeing that person, connecting with that person, speaking with that person, understanding their social story.
That was Tracey Human talking about caring for individuals with intellectual or developmental disability, or IDD. She's a pain and symptom management consultant who provides education and palliative care in the community. She's joined by Bob Parke, a bioethicist, in this episode, where we discuss how the 7 keys for a life-changing diagnosis apply to individuals with IDD and their families. It's an eye-opening episode where we discuss the heart of palliative care, which is how to achieve truly person-centered care for conditions that aren't usually thought of as life-limiting. Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Tracey, Bob, so glad you could join us. Welcome to the podcast.
Oh, I'm delighted to be joining you.
And I'm happy to be here with you as well. Thank you very much for the opportunity.
Our pleasure.
So, Tracey, I know you are a pain and symptom management consultant.
Correct.
And Bob, you are a bioethicist. Maybe you can tell us in a few sentences what you both do on a sort of a daily basis so our listeners catch up on your work.
Yeah, absolutely. I would refer them back to one of your earlier podcasts with Mahogany Hines. She spoke for the whole collective pretty much of the consultants across the province of Ontario. But our role is to capacity build in all things palliative care, in all sectors, predominantly in the community, long-term care, community service sectors, primary care, and with the additional mandate to coach that knowledge to practice, because we know that education alone doesn't promote the level of change that we want, and how things look, smell, feel, and touch is often different in real life. Mm-hmm. And to be able to mentor that into what it would look like for the population a particular organization or facility serves, as well as policies and procedures and those sorts of things to support using the right tools for the right task. And then we sit on a lot of advisory, we partner in research, not only in Ontario, but across the country, many of us, and we sit on numerous tables. I had the benefit of being on the OPCN, the Ontario Palliative Care Network's Clinical Advisory Council, and other places in the past, other networks in the past. And so that's what I do.
And that's where I met Tracey, was on the OPCN Clinical Advisory Committee. And I'm Bob, I'm the bioethicist, not Bob the builder. And I've been a bioethicist for many years in a community hospital. I was at Humber River Hospital for many years, and then I retired in 2018 to be a caregiver. But at the same time, I was still doing some work at University Health Network, with an overlap at Surrey Place, which is a center that works with folks with intellectual disabilities. And something that I believe very, very strongly in is that healthcare is a continuum, and that the majority of healthcare is in the community, and that hospital care is an episode of care. And something I believe very strongly in is to try as much as possible to go upstream to do some of the work that we need to do. And Sammy, I've heard you speak about, the notion of the natural course of an illness. And one of the examples that challenges me is folks who don't know that their loved ones with dementia will have swallowing problems. And they end up in the emergency department with aspiration pneumonia. And so I try to get out to the long-term care homes, meet with family councils, and do a little bit of a teaching in preparation for what might happen. So for me, there's a prevention part of bioethics that has been very important to me.
I wanted to start with palliative care and then get to IDD and just as a subsequent question. But we were just talking about this today, Sammy and I. We really were trying to, as we spread our message, talk to people like yourselves who are providers and patients and families as well, like real firsthand experiences, particularly of this idea of the keys that we've put out in our podcast, and I know you've listened. So I guess my question is really about, in your work in palliative care or your own personal experiences, do these keys resonate with you, and how are you using them?
I would say they absolutely resonate. And it is certainly things that those of us that have been practicing in palliative care, and I've been doing it for 35 years now, it resonates highly. Not only in my professional work, but also in my personal life, because I'm the baby of 7 siblings, and I'm the last survivor of my siblings and was involved in their end-of-life care journey. So 6 of them and 2 parents, and a few friends and their parents. There's a lot of personal journey there. And it's an interesting comparative because it was only because of some of my work professionally that it equipped me for the right questions at the right time and stages. At the same time, there is that duplicity of being the sister, being the daughter, and the emotional burden and the changes you experience through that. And sometimes you can't be, in my instance, the nurse and the sister at the same time. And how you do that dance, because it's really a dance, this whole journey, right? It's like a symphony that comes together, and how do you navigate it? So I think the 7 keys are a wonderful summary as a starting place, and empowering the individual and family. And we want to do that a lot in palliative care, right? For as much as the person and the family want to know, and kind of meeting where they're at, and then kind of doing gentle nudges and tugs here and there throughout that journey. So we don't see what many of us have seen, which is pretty frightening end-of-life journeys with a lot of suffering attached that could have potentially, and in many instances, been prevented upstream. Yeah.
How about you, Bob?
Certainly. There are a number of the keys that certainly resonate with me, and both personally and sort of and in my professional experience. And one of the ones that resonates very strongly with me is expect ripple effects. I mean, I was listening to the podcast about this, and I thought how true it is because of the ripple effects that the caregivers are going to experience. And for many caregivers, they themselves may become ill with the caregiving burden and need to be prepared for what can they expect, what resources might be there to support them as well. And one of the things I value in the philosophy of palliative care is we're not just caring for the person. It is their social support network. And I would say however that person defines it, because people may define family differently. The other thing that's kind of important to me too is, the walking 2 roads, I think it's a lovely way of thinking about that. And thinking about hope too, because I've been with palliative care physicians and been on a journey with the patients and families around, okay, how does the hope evolve as we get towards the later stages? I mean, I may hope for a cure 2 years ago, but now as we're getting closer to the end stages, what am I hope for? I hope to reconcile with family. I hope to have less pain. I hope to have comfort. And so we shift the hope and still give them something to look forward to. And I do want to think a little bit, and I don't know if our dialogue will allow for this, a discussion about tailored in the population with intellectual disabilities. And I would certainly say, from a cultural point of view, we have to think about who does the person want available to them to help them with decision making, because the persons that are on the hierarchy of decision makers may not be necessarily the persons that they want and need. So we could talk about a number of things.
Okay.
Come on.
Yeah. I mean, that was one of our hopes, which was that as we were thinking about this, as we thought about this was about end of life, and then palliative care is much broader and going upstream. But we had always, as we sort of were saying the 7 keys, it is more than just about dying. It is about living well. It is about chronic disease, chronic and progressive disease even.
Yes.
And so we had always thought it could be applicable to other populations without necessarily having that, frontline experience that you have. So we are so honored that you're going to what your thoughts are about how these keys could apply to a different population, the individuals with intellectual and developmental disabilities, which, the acronym for that is IDD.
Right.
Correct. That's correct. That's what it is here in Ontario, Canada. Some areas they call it developmental disabilities. Internationally, they may call it learning disabilities, like in the UK and the European Union. Those are the sorts of things that they call it. But as I was preparing to be able to come to spend some time with you today. I was reflecting about the word waiting room revolution. And revolution is a powerful word and a much needed word, particularly when we're talking about specifically palliative care as it relates to people living with an intellectual or developmental disability. Because there's specificity within IDD. And what I've learned over the past couple of years, I've been serving that population for 14 years as a specific going out to target to capacity build and be able to engage with them. But we developed a committee at the end of 2019 for Ontario. It's the Provincial Intellectual and Developmental Disability Palliative Care Committee. And what I've learned over the years that we've been working together and developing a toolkit for Ontario is the rich supports, cultural and services, and the approaches that are used within the developmental sector. And what's encouraging is so much of the work that they do in the developmental sector is about living. And that's what palliative specialists say, right? Palliative care is about living until you're not, right? And so that's their focus of work. And when you look at their resources, their models, their guides, and how they go about delivering services and their approach to quality of life and enrichment and everything that they do, it closely matches the model to guide hospice palliative care and the palliative care approach. The only difference is the terminology is different, right? The energy, the approach, the heart behind it is exactly the same. The personhood, the value of seeing that person, connecting with that person, speaking with that person, understanding their social story.
Yes.
And how we modify, because within the IDD group of individuals, there are those who have mild, moderate, severe, and profound disability. And how do we create that branch that carries across to see the personhood in individuals with severe and profound? This is where we see the greatest amount of diagnostic overshadowing, unconscious bias about value.
So I think you're saying you're not talking about end-of-life care for people living with IDD, but rather a palliative approach to care all throughout for people living with IDD.
I want people to recognize that when we're talking about people living with IDD, it's not just about people with Down syndrome. I want you to be, our listeners to broaden their horizon because there's a lot of opportunity around the various different etiologies and conditions for learning. If you can do it well, air quotes, get it right, for people living with IDD, you can do a palliative approach to care, even in the most complex of cases, proficiently and or expertly. If you can do it well with the needs here with this group, it's quite remarkable. And so there's all kinds of places that, I would encourage people to think of, where will you, within your purview, your organization, your services, begin to think about how you can engage with developmental services? Because they're not on our palliative care radar. Residential hospice is, their community outreach hasn't made it a strategic initiative, which would be beneficial. There are pockets of excellence that are happening out there. And how do we go to where they are? Hospital is not the right place for end-of-life care. Hospitals are incredibly traumatizing and distressing and cause these individuals to deteriorate quicker. Long-term care is not the right place. Developmental services that work in supported independent living homes, congregate living homes, and the complex high-intensity needs homes want to keep the individuals at home whenever possible.
And so what are the barriers to supporting them at home, or just getting the best care more generally?
There are challenges, for example, with people meeting issues like diet, or I think diagnostic overshadowing is what Tracey said earlier too, that the prejudices that we feel sometimes when we look at somebody and think, oh, they have an intellectual disability, and we may not necessarily think that they've had a full and rich life, and because of that may not treat them in the same way. I remember a consult that I got when I was in the hospital, where a person came in from a group home, and the physician wasn't quite sure how aggressive to be in the diagnostics and therapies and treatments for this particular person. But I'm grateful that physician consulted with me, and I called the group home and found out that this person was a member of the disabled sailing. They were a baseball fan. They enjoyed cooking in their place when they were able to do that. And they had a loving family within their group home. And when I was able to record and tell the social story of this patient, the care changed. Now, I don't think it should, but it indicates a sort of a risk. I'll let Tracey just say, speak a lot more fulsomely than I can. But one of the things that I've had concern, for example, with the folks with Down syndrome who may experience dementia before the age of 65, because they're under 65, they may not be eligible for a consult with a geriatrician who may know very well how to manage dementias. And so that for me is one of the practical concerns with this population. And so thank you, Sian, for giving me an opportunity, but I'll turn it over to Tracey to elaborate more.
Thank you. So globally, people living with IDD fare worse across all healthcare indicators. There is a huge disparity in wellness care. Number one, that then impacts them, that results in premature death. It's interesting when you think about the average life expectancy for the majority of individuals. Now, there are always those individuals that, are on either side of the continuum, but we're just talking about on average. Most of the individuals in Ontario, at least, and I suspect is the same throughout Canada. It certainly was in Manitoba, where I was born and raised before I moved here, were raised in institutions.
Yes.
They were separated from their families as babies or as infants or as young children. The healthcare professionals of the day felt it was better for them to be in institutions. That was not the case. The result of that was their life expectancy on average was 35 to 36 years of age. That was because of the neglect that they received. And unfortunately, they are survivors of multiple levels of trauma: physical, emotional, sexual trauma, forced sterilization, the list goes on. Now, this was done at the hands of healthcare providers. So when we see some of the deficiencies in accessing primary care, and when we're talking about those who are at chronic, advanced, and end-stage illness, the individuals that were in institutionalized care before they were moved into congregate setting, and the last ones here in Ontario just closed in 2009, the last 3. These are the individuals that we're seeing now in our healthcare stream. They're terrified of us because we were the kinds of people that did this to them. And so there's a lot of healing and a lot of change in approach that needs to happen from healthcare providers. And that's where we leverage our developmental service workers, right?
Yes. So the DS workers, or the developmental services workers, they are so critical to ensuring the best care for people living with IDD. I don't think I realized how much trauma they could have faced before.
I'm wondering if it might be helpful for the listeners, if maybe we could list some of the conditions that result in intellectual and developmental disabilities, just so we're not being too vague for the listeners about who these people might be.
When we talk about some of the common etiologies, when we're talking about the deletion syndromes that, like Rett syndrome, Williams syndrome, Prader-Willi, Smith-Magenis, Angelman, Fragile X, those are all under, deletion, chromosomal deletion. We have our Down syndrome, which is an additional. And then we have fetal alcohol syndrome, some of the individuals that are on the autism spectrum disorder, and some individuals with neuromuscular diseases, if they fit the IDD definition. And so under the Ontario Services and Supports to Promote Social Inclusion of Persons with Developmental Disabilities Act from 2008, developmental disability, and here on the podcast we're using the term IDD, is an umbrella term for different disabilities that involve the person that has prescribed significant limitations in cognitive functioning, adaptive functioning, and those limitations originated before the person was 18 years of age, are likely to be lifelong in nature, and affect areas of major life activity, such as personal care, language, skills, learning abilities, the capacity to live independently as an adult, or other prescribed activities. And so in some instances, someone with cerebral palsy would not fit that criteria at all, right? And then in some instances, we have more of a dual diagnosis scenario with those challenges that they're living with, and they have CP, right? And so there's individuals with, that are living with the consequences of maternal rubella, that had meningitis, and so on. And so it really is incredibly broad and highly specific at the same time, right? It's very individualized, what we're talking about, but there is a framework that we're looking at. Yeah, so, the prevalence is 2 to 4%. That's what we're working with right now as our estimate. Knowing that it's more than that, and that majority of these individuals would benefit from a palliative care approach. Now, the palliative care approach and the tools has to be modified because our gold standards don't translate well for these individuals at all.
Yeah, do you want to elaborate? That was one of my questions. There are a lot of tools to try to help people to apply a palliative care approach. What are they missing that's not capturing? How do they need to be modified? You just sort of hinted at, yeah.
So if we're talking about tools specifically, so those that are familiar with palliative care will be familiar with the palliative performance scale, the PPS. That doesn't work. because many of these individuals have distinct frailty and they would score as end of life their whole life.
Yeah.
Mhm.
Particular are moderate, severe, and profound. So the PPS doesn't work. If you are an expert and a specialist, you'd be able to do the translation,
Mhm.
but it's not going to catch people.
Mhm.
The palliative prognostic index has benefit, but we tend to layer that on at end of life anyways to refine clinical estimated survival time. The gold standard framework is wonderful, and clinicians would use that because of the secondary health concerns and comorbidities, but that's not helpful for earlier ID out there in the community. It's highly a clinical tool. The surprise question is wonderful, but you have to have some idea what's informing that surprise question, right?
Mhm.
When we talk about things like pain identification and screening for those who can self-report, the ESAS is too abstract. 0 to 10 doesn't work, right? It has to be something from mild or moderate that is a 4 or 5 point scale. Is it a little bit of pain? More than that? Really bad, right?
Mhm.
That translation of the tools, or more than you can even take, right? The nonverbal and cognitively impaired tools. Now, here's the nuance. Just because somebody's nonverbal doesn't mean that they are profoundly intellectually disabled. When we talk about the early identification earlier about needs and where are the needs changing, what does that picture look like?
Yes.
We're needing to compare baseline to what's changed in the baseline for a
Mhm.
person living with IDD.
Mhm.
Tracey.
And the tools need to have been built around baseline assessment. And so when we talk about the earlier ID, we're talking about the PALI tool, PALLI tool. That's designed specifically for IDD, early identification. It goes across all their functional domains,
Mhm.
right? And forces by the questions that we're comparing to baseline, including if breakthrough seizures are emerging. We're talking about the gold standard framework. The toolkit that we're developing has been modified specifically for IDD. So how do we incorporate that with the existing gold standard? If we're talking about pain and symptom screening, well, one of the pain tools that would be used would be called the CPS NAID, N-A-I-D. That's designed, has been tested, and has 94% reliability and specificity in people where we must translate behaviors to identify pain. And so you begin to, and that's just a bit of a dipping everyone's toe in the waters. I mean, I could talk for hours about the differences in
believe
how
you.
we layer the tools, and layer the tools, right, to
Yeah.
equip everyone. But that gives a start.
Yeah,
Right.
I'm thinking about a patient that I had as you're talking, as someone who had intellectual and developmental disabilities, and he would have met the criteria that you mentioned. And I'm just trying to think about like what was unique about this particular situation. He lived with his family, he couldn't live independently, and he developed a cancer.
Mhm.
And the things that I think stuck out for me were something that you've mentioned, which is this idea of baseline, that it is super important, or it was important for us to really trust that the family knew this gentleman so well that they could pick up on change, that their report of something being different or worrisome or concerning had a lot of value, because they, based on their relationship and knowing the person, they were our best early identification tool, because they pick up the change
Very
quite
subtle.
quickly. Yeah. And so they know them so well because, of course, families have typically, or in this scenario, I shouldn't say typically, been very vigilant, had spent a
Mm.
lifetime protecting and
Yes.
supporting this loved one. So they knew them
Yes.
intimately, almost like, I can just imagine like a mother knowing their baby, like you just know that what the baby needs, or
Yes.
not that these people are babies, but it's just
Right.
that intense relationship of caring that puts them in a position with credibility, the families, right? And so
Yeah.
that was one huge thing. Another huge thing that stood out for me was how protective the family is, and how any kind of healthcare provider entering onto the scene has to be, or any change in care setting, we have to be uber mindful
Yes.
of the mama bear syndrome,
Yes.
which is to the person's benefit, that this person comes, like you said, Bob, as a unit of care with a very vigilant person right beside them. And so we do have to treat the families with the utmost respect and not dishonor the fact that they are not just privy to our care team, but they are the care team, and we are invited into their care team, not vice versa.
Yes.
Yeah, that's
And
beautifully said, Sammy.
yeah,
That's
and
beautifully
then
said.
the last thing is what you said about assessing symptoms, that again, it's not typical how we would assess the symptoms. And again, a reliance on the family to tell us, how do you know that your loved one is in pain? What is it? Like looking at behaviors and change in behaviors, but that we use a whole different spidey sense around symptom assessment with this
Yes.
patient population, right? So
Yes.
it truly is a really unique, reflecting on my experience with this person and their family. It was completely unique, humbling,
Enriching,
enriching. And I have to
right?
tell you, like, just, I'm constantly amazed at families who care for a loved one while they're,
Yes.
Right.
declining at home. But this
It leaves
particular,
you in awe,
this
right,
scenario
Sammy?
was,
Yeah.
unbelievable,
Mm.
and very, okay. And the family had more resilience than the average family because they had
Yes.
already been doing it a lifetime.
Yes.
So there was a different hardiness to the family,
Yes.
and threshold for worry, because this was just part of their life. It wasn't like me becoming a caregiver all of a sudden for
Hmm.
my mom, let's just say. So anyway, very unique and
Yeah.
huge, humbling experience for
Yeah.
me.
Tracey and I are, as well as I know you are too, a big fan of Dr. Harvey Chechnoff.
Mhm.
And certainly we think about just what you were saying about the family, and what do you call that? The patient dignity question.
Mhm.
And that patient dignity question, and hearing and we would say in the DS sector about the social story, and knowing the
Mhm.
person and knowing the family, knowing the resources, and that teaches us a lot. And Tracey has this wonderful story that I've drawn on about how in a group home where a person was cared for very much, and it was a very subtle change that identified that this person was in pain, and this person was what do you call it, stroking the tassels of a lampshade. And when he was in discomfort, that's what he would do, stroke the tassels of the lampshade. But people,
It was a new behavior. It was a new behavior. Yeah.
Mhm.
we're not figuring out this is a new behavior. What's different about this person? And then Tracey was able to identify what that is. Tracey, you've used the language of a behavior translator to have somebody who understands what that behavior meant. And when it was understood with that when he was in pain, he was stroking and soothing himself with the tassels on the lampshade, then there was a response to that.
Yeah, and then we could move forward with it. It wasn't a typical behavior to stroke the tassels. It was new, but it needed, the extra eyes coming in to say, is that a normal behavior?
Yes.
When did that start? Then I could tie it to, yes, something had changed there. medically, and then we could start investigating those sorts of things. But I love the fact that you talked about these amazing qualities of these amazing
Mhm.
families.
Mhm.
And I would add to that is that we have a lot of disenfranchised people living with IDD that no longer have contact with family
Yes.
because of that institutionalized separation.
Mhm.
Or, they're in their 40s, 50s, 60s, 70s. So family is deceased, or they have elderly siblings that may themselves be quite ill and or living with their own health challenges and cognitive impairment and in long-term care. There's a lot of different reasons for it, but people with IDD consider their direct developmental service workers family.
Yes.
Yeah.
Now, healthcare providers have a hard time with that because we like to talk about therapeutic boundaries and all the rest of that. We're just going to have to get over that. We're just going to have to find a way to get over it, because how they function works. And the individuals will say that my service worker is my trusted person. I want to discuss everything with them. And if I can't talk to you, you need to listen to them. We need some legislation changing, right? That has wording around the person that knows the individual best, right? And that's our supportive decision-making, where Bob's a master at.
And I've learned from the Iris Institute, Dr. Bill Sullivan, Dr. Michael Bach, and others about supported decision-making. And there are other provinces like in Alberta and British Columbia, in which they do have legislation which includes, who should be available to support the person. Because, we've had practical experiences of where a person with an intellectual disability came into the hospital, and the staff members at the time said, "Oh, we're not letting the trained worker come in because they're not on the hierarchy of decision makers." Whereas if they were in another province where they had the form that said they are the supported person, they would be allowed to come in. And the difficulty for the poor hospital staff is because they didn't allow the person in who knew the person well in terms of how to communicate with them, where's the best place to have discussions. They ended up with behavioral problems, which then prejudiced the care all the way down. Whereas if they had allowed the person in from the get-go, they would have had a better care experience for the patient for sure. And in this case, the substitute decision maker, a family member, wanted the trained worker in. And of course, the patient, our person with intellectual disability, would have gotten the appropriate care. And this was a situation which may have included rehab, and actually ended up with a situation where they were denied rehab because of the behavioral response that was evoked earlier on. Now, so I've come to appreciate that, and I had to do some cajoling with patient representative in the hospital and so on to allow for the patient's worker to come into the hospital. But I've sort of learned subsequently from David Lepofsky, I think is his name, a lawyer who himself with a visual disability, said I could have used the human rights legislation to say that there's a duty to accommodate, but you don't want to bring down the hammer if you don't have to. And if we look, there are supported decision-making tools, like in Western Australia has a very good tool. And it does things like, where, who, what technology is best to use. Because the goal is, let's give the person the best chance to see if they can participate in their decision-making. And as Tracey will say many times over, that they may not be able to verbally communicate wishes, but they may have another way of doing it. And lastly, I would say to this point that even if we don't get consent from a legal consent, if we can get cooperation. In my bioethics world, sometimes we may say we can't get consent, but can we get assent? And so therefore, if that same person has to go off to diagnostic imaging, to a CT scan, and with that scary thing that goes around you, well, maybe they might be more calm and as they go through that experience because of the trained worker who helped them understand what is next going to happen to them. And
Indeed.
So I just wanted to make that point quite strongly.
Okay, so my question is this. You both have talked about the incredible need for a different kind of care for IDD, for people with IDD. And this podcast, as you know, really has a big centerpiece of the 7 keys.
Mhm.
So I'm just wondering if you can speak a little bit about if you think or how
Yeah.
which 7 keys or which of the keys really apply to this and in what ways.
All 7 keys apply.
Mhm.
Yes, I was just trying to think of which one to speak to
If we're
most.
talking about moving from in the dark experience to in the know experience, how do we equip family, person living with IDD proper based on the level of severity of disability that they're living with? And their direct service or extended direct service, specialists teams, right? To know, to do meaning making, what we're looking at, what may be on the near horizon or future horizon, so that we can be prepared. That walking 2 roads aspect, about hoping for the best and preparing for a different outcome, right? And often, and that can be frightening when we're trying to massage and nuance that. But I talk about very often with individuals about, do you drive? Yes. Do you have a car? Yes. Do you have car insurance? Okay. So you have planned for a potential accident or potential serious change, unexpected change, et cetera, or an expected change, putting on your winter tires, those sorts of things. What about in the house? Do you have carbon monoxide, or do you have and fire alarms? So if a fire alarm is going to go off, now we've got a crisis situation, and we all have life experiences that happens with. What people living with IDD tell us is, stop treating us as if we're invisible. Number one, talk directly to me, right? And when I don't understand, my support worker will help, right? So that, how do we prepare for moving? We need to, you don't know what you don't know, so we need to help and start having really good conversations about what's your understanding and what's the meaning making. If we're talking about being informed, that's part of it, right? When we started this work, I know that most people wouldn't have thought that most IDD etiologies are life-limiting, right? And how life-limiting. The research shows us, and the premature death ages show us, that their chronological age is one thing, their biological age is 20 years older. And so we need to start thinking about what we would do for a 65-year-old at 40, right, in this population of individuals. And if their average life expectancy, which is still true, is 55, then we need to be having this shared conversation and understanding early. We're talking about understanding style.
Can I just add too that picking up on things that Tracey has said all throughout this, and Sam, you've asked, I was thinking about the ripple effect too. And for many people with IDD, they are living in group homes, and the people who are affected in the ripple effect are hidden, because we think mostly of families, we think of spouses, of children, and so on when we think of that. But in a home where somebody has known them sometimes for years, and they're seeing changes and they're knowing something's happening, so they're experiencing some degree of anticipatory grief. And then of course, when something happens, they do experience grief, but we may not necessarily rally around a care provider in terms of grief support in the way that we would if they were the sister, the brother, the mom, the dad. So there's a ripple effect that's happening that's hidden, and so we need to take that into account as well. I don't know, Tracey, maybe she articulates better than I do, that whole zoomed out notion. We need to try to get involved earlier and go through what is the natural course of this illness and what might you expect?
Mhm,
And,
mhm.
and because of the disability, what barriers might you expect and what can we do to remove some of those barriers ahead of time? So there's a lot that we could say, but thank you.
I'm thinking
Yeah.
about about a person who is living in a group home. I'll just call it a
Mhm.
group home, a supported living.
Mhm.
Their family might not be right there, or they might not have family. And how you both have mentioned that the care workers, the support
Mhm.
workers, become their I wouldn't say
Family.
family of choice, because they
That's
didn't
right.
necessarily choose them, but they're their family, right?
Mhm.
And my experience in those scenarios has also been, okay, so not only do they also feel very protective and know
Mhm.
their clients, residents,
Mhm.
people so well, they also have a really hard time because they have advocated so hard and so long for the best life possible for these people, and to advocate that they're not brushed with one stroke.
Yeah.
That when it does come time to talk about decline,
Mhm.
the normal decline, making decisions about not treating or discontinuing things like feeds or hydration, or in some scenarios talking about, like I'm thinking of like, stopping a tube feed, let's just say.
Mhm.
It is really a difficult shift when you have spent decades
Mhm.
propping someone up. Not just difficult for families, but for healthcare workers
Yes.
to I, the only word that comes to mind is grasp that, to accept
Mhm.
it, like to shift lanes with us,
Yes.
because they've been fighting so long and so hard.
Yeah.
It does get really complicated, actually,
It
Yes.
can.
in so many different ways. Yeah.
It can. You know, one of the ways that I like to approach it, because I've been involved in many of those conversations,
Mhm.
like you, Sammy. And one of the things that I think is important, and where I think we can make quick gains, as we're empowering every set of eyes and
Mhm.
hands and hearts, is around the meaning making of what you're seeing of where the individual is in their journey.
Yeah.
So that it's not a sudden conversation because
Yeah.
we've had an exacerbation, we've ended up in ER, and now everything needs to be withdrawn.
Mhm.
And number one. Number two, allowing the time for that information
Mhm.
to be absorbed and processed, right?
Mhm.
Don't go in and think you're going to stop the feed today,
Yeah.
right?
Yeah.
Those sorts of things. There just needs some time to catch
Mhm.
up with some of that
Mhm.
information. But I really do echo what you're saying about yes to everything that you said for family.
Mhm.
And the language is the chosen or trusted family, and
Mhm.
that's their direct developmental service worker,
Mhm. I like that, the
right?
trusted family.
Exactly. And sometimes, and quite often, family do defer
Yeah.
to that team when
Mhm.
it's in, a congregate or supportive independent living, because they have worked and cared for them
Mhm.
for 10,
Yes.
20 years.
Mhm.
Some of these wonderful people. And so the the whole point is, do you have and will you take the time to have the heart to address emotion first
Yes.
before you address all the other information,
Mhm.
right? I think that's always been very successful for me.
Mhm. Mhm.
And
Mhm.
can I share with you? Just Tracey articulates something in one of your last keys there: invite yourself, initiate conversations about what to expect. And so in I think a very parallel experience, there was the person who had an intellectual disability. She was in the hospital. The team, Tracey and others, I believe, went to the home. They had conversations, asked questions about allow people to ask questions about what to expect. And then the person was able to be returned back to their their home and in the place that they knew. And this person with intellectual disability, the story that I'm familiar with, they were sufficiently capable to say, I want to go home.
Yes.
They didn't want to be in the hospital. And our colleague from Central Community Living said it beautifully. When she got home, Mary is still Mary. She wasn't this disease. She was this
Yes.
person. And they, because of the preparation that was done, Tracey and others, she had, a good care at home, and she died at home. As somebody in my own situation, died at home in amongst people whom she cared for and who loved her.
Oh, that's such a great story, Bob. Thanks for sharing that. We'd like to end our interview with asking each of you, is there something that you're excited about for the future? Or if you have any advice for patients and families?
Well, I'm very excited about our intellectual and developmental disability palliative care toolkit for Ontario that's going to be coming out this year, to equip both healthcare and the developmental service sector, and how to build a collaborative team. So it's all about, what are we looking for? What are the tools we use? How do we build the team so that both sides are working with a foundational knowledge, and then other people will come and join, and it will evolve from there and grow to become a movement. I mean, in the past 18 months, the word is spreading like crazy, and we're nonstop being asked to come talk about this.
Yes.
And so we're so excited about the heart displays from so many providers in healthcare and hospital administrators and regional directors. And it's like the whole system leveled down, wanting to know how can we be a part of this, and what do you need from us? I think the biggest takeaway message that we can do is just please take the time. Recognize that people living with intellectual and developmental disability are people. They have personhood, they have value, they come with trauma. They are afraid of us in the healthcare sector. They've experienced things that really, from a historical context were genocide, and even, in Canada. And so when their family or developmental service worker comes with that fierce protective energy or questions or approach, I really want healthcare providers to look at that as a positive. Thank you for doing that. And I am going to join you with that so we can get that mistrust to come down, and then really, really get to know the person, their social story. Stay away from the assumptions of what quality is. Quality is what the individual says it is, and their life is what the individual says it is. It's not ours to measure. And if the individual can't tell us the answer to those things because they have really profound quality, is what the people that have been loving them, their life, tell us, right? And we hopefully get to journey with them along a natural journey, just giving the best possible whole person centered care available, picking the team that has the knowledge, skill, and experience to do that.
How about you, Bob? The last word.
Yes, thank you very much. A few years back, there was an article, I think it was in the New England Journal of Medicine, about palliative care. Isn't it just the best care? And I love that. I love the question and then the answer that kind of flowed from that question. One of the things for me is I do hope that folks will get to know us as bioethicists, because, not many people know about the role of bioethicists, and that we can be present to help with people are wrestling through what to do. And that can be patients, families, and all staff. So that's one of the things that's very important to me. And that bioethics is integral to all that we do. And we may not always recognize it, but we're making a judgment about the good that we want to do. And one of the things that I'm hopeful in Ontario, and we've been a little bit slow in this, and we've said this a few times, is picking up on the way we nuance the Healthcare Consent Act. And I think about it from the perspective of folks that's Indigenous people, when I think about people with different cultural backgrounds, and of course, when I think about, folks with intellectual disabilities and who they would need present to help them. And I think we have an opportunity in Ontario to sort of start to shift that thinking now and to nuance that. So that's one of the places where I'm hopeful. And I'm grateful that you have given us an opportunity to share our work, and we're looking forward to the toolkit being available. And Tracey is so right. We are being asked time and time and time again to present because people are interested, and we think this is terrific.
I really look forward to learning more about your toolkit that's been adapted specifically for this population. So kudos to you guys, and thank you so much for being on our show. I've learned a lot.
Thank you both so much for joining us today.
Thank you for having us.
Thank you.
Thanks for listening. Don't forget to rate, review, and subscribe if you haven't already. You can visit our website, waitingroomrevolution.com, to learn more about our movement and how you can join it. The podcast is produced by myself, Kayla McMillan, Valerie Bishop, Shilpa Jyothi Kumar, and Maggie Sivak. Our theme music is Maypole by Ketsa.